All right, so I'm going to call upon our next speaker, Norgrove Penny. Norgrove has been a great inspiration to all of us, and he's been a mentor to Dr. Sabatini, who's our partner here, and he's had a lot of experience in Uganda. So Norgrove, please go ahead.
Good morning, everyone, and thank you, Sanjeev. I'll just try and get this now expanded for you. I'm speaking to you from Canada. Are you seeing the screen properly divided there? I hope so.
Absolutely. Yeah, looks great.
Okay. Limb differences in children in the Ugandan context. I have no disclosures. I lived and worked in Uganda for 6 years between 1996 and 2002. At that time, I was the lone children's orthopedic surgeon in the country, working mainly on outreach in very austere circumstances. Now, however, Korsu Hospital exists, a specialist children's orthopedic and plastic surgery hospital, similar to a Shriners Hospital, with 6 modern operating theaters, 5 national orthopedic and 2 national plastic surgeons, training a whole new generation of specialists. In this talk, I want to consider both the austere setting and the specialized setting. I give credit to my Ugandan colleagues for their continuing work and some of the cases I will show you, all of which were undertaken in Uganda. Children's surgical services in sub-Saharan Africa are so much more needed than in developing countries. There are so many more children, almost half the population, most children living without access to preventive care. The burden of limb deformities in this setting is profound. What kinds of limb deformities do we need to treat in the Ugandan context? The most common by far are chronic osteomyelitis and septic arthritis, followed by ambulatory bone deformities from nutritional rickets and true Blount's disease. Of course, a host of other limb differences are present in late presenting or neglected forms, as shown to us by Dr. Izagwaba in the previous talk. Why do we see such profound pathology? The impact of poverty individually and nationally cannot be overemphasized. There is a lack of awareness, lack of primary care, lack of transport and financial resources, lack of public or private insurance, lack of trained personnel, lack of technological and infrastructure support, and the public health facilities are simply overwhelmed. The bottom line is lack of access. There's no such thing as a simple, straightforward case in this environment. Almost no operation that I did in Uganda would I have done in Canada, and almost no operation I do in Canada would I have done in Uganda. There are likely hundreds of thousands of children with untreated chronic osteomyelitis in low-income countries. Here, a typical presentation of osteomyelitis of the tibia, including a large diaphyseal sequestrum with flimsy involucrum starting to form around it. Wherever possible, do not remove the sequestrum. Facilitate drainage and wait for the involucrum to become more robust. Then the sequestrum can be removed safely, leaving healthy structural bone behind. This child presents with osteomyelitis of the femur, which contains a huge sequestrum of much of the distal femur. This requires urgent stabilization, for a pathologic fracture is imminent. An external fixator has been applied. Note that fixation is through the sequestrum, which has been retained. Over time, this allows involucrum to form and become more robust around the sequestrum until there's enough structural involucrum to allow removal of the sequestrum. An important lesson of osteomyelitis is, wherever possible, do not remove the sequestrum until the involucrum has formed. Use external fixators to preserve length. Antibiotics are not the mainstay of treatment. In many cases, the sequestrum cannot be retained, or the patient presents with an existing segmental bone loss. If the gap is smaller, posterolateral grafting or papillografting can be contemplated. For a bigger gap, single bone transfer. These are useful procedures in the austere environment. This is the Huntington 2-stage fibula transfer, an ipsilateral fibula pro-tibia procedure. The procedure can also be done by fibulodesis, cross-grafting at the proximal and distal ends, creating a one-bone extremity. Where there's a larger bone gap with deformity and better surgical infrastructure, options including the muscle allograft technique, bone transport, or a vascularized fibular transfer. In this case, the sequestrum could not be maintained. After debridement, an acute bone transport was done, resulting in normalization by 1 year. We are fortunate in having skilled plastic surgeons and microsurgery at Corsu Hospital these days. In this case, an external fixator was applied, a soft tissue flap rotated, followed by an autologous vascularized fibular flap. After 6 months, the fibula is incorporated. All these techniques have significant complications, including non-union at the docking sites, graft fracture, graft absorption, recurrent infection, and hardware issues. These are complex cases requiring advanced skills and long-term vigilance. Untreated septic arthritis of the hip, usually coincident with femoral osteomyelitis, is catastrophic. Lack of access to treatment in this child allows us to see the natural history of progression to complete dissolution of the hip. The mainstay of treatment in austere settings is debridement and Girdlestone's arthroplasty. Although the hip is mobile and relatively painless, the leg is short and weak. When spontaneous ankylosis occurs, the hip is in flexion and adduction, resulting in impaired gait and lumbar spine stress. Simple corticotomy realignment with external fixation results in much better function. The Thomas test shows usefulness in planning and the correction and the improved functional position after correction. What about where the hip is not ankylosed and the leg is short, unstable, and painful? Excuse me. If more advanced technical resources are available, the Ilizarov pelvic support osteotomy is a wonderful salvage. This consists of a valgus osteotomy of the proximal femur and a distal varus lengthening osteotomy. Here, a 17-year-old patient of mine after debridement, resection of the hip with short, weak, and unstable leg, treated with stacked donated external fixators, resulting in pelvic stabilization, equal leg lengths, and realignment of the mechanical axis. Pain-free range of motion of the hip is remarkably good. Another patient of mine, 14 years old, with a painful, unstable post-septic left hip, also treated with stacked donated monolateral fixators, with equalized leg length and pain-free ambulation without crutches, and good range of motion, allowing squatting and a big smile. I've heard some people say, why not just wait and do a total hip? In which case I'm in agreement with Charlie Brown. Oh, good grief, what are they thinking? Ambulatory deformities are also very common, particularly due to calcium deficiency rickets and true Blount's disease. True Blount's occurs and is familiar to North American practitioners. Vitamin D rickets, relatively uncommon. But calcium deficiency rickets is very common and is largely unknown in the developed world. This results in irregular, widened, and deformed physes with diaphyseal angulation restricted to the lower extremities. Simple osteotomies with pins and plaster techniques are very appropriate in austere settings without image intensifier, including the possibility of plateau elevation, as in the case on the right. In this case, a simple closing wedge osteotomy with external fixation allowed acute correction and is also possible to do without image intensification. With severe deformities, which are common, where there are very severe deformities, and appropriate infrastructure and skills and access to an image intensifier, more creative and sophisticated options are possible. In this case, I used donated T fixators to perform gradual correction by distraction hemicalotasis, producing accurate mechanical axis correction. What about guided growth? The problem is the difficulty of follow-up. The children get lost back in the villages. I have seen terrible cases of overcorrection with unreconstructible deformity. So this should only be done if follow-up can be assured. And this has certainly been shown to us by Scott Nelson. I much prefer pin and plaster in these cases. In 2017, we ran a mini Baltimore limb deformity course in Uganda, courtesy of a visiting faculty of Drs. John Herzenberg from Baltimore, Christoph Radler from Vienna, and Mark Eidelman from Israel. Tailor spatial frame training was accomplished and some complex cases like this one done. A supply of donated used fixators was made. Dr. Emmanuel Owachu picked up on the technique at Corsu and has become the local specialist. He has subsequently performed 231 angular deformity corrections, of which 48 were frame cases. This is one of his severe Blount's cases treated with TSF. It's obvious, therefore, that complex limb reconstruction can be performed successfully in lower income countries with appropriate skills, training, infrastructure, and equipment. I hope it can be seen from this presentation just how valuable external fixators are for limb reconstruction in this environment. The most valuable equipment donation we can make are used or new external fixators, including TSF components. There is an elephant in the room, however. Children with fixators cannot be sent back to the villages. They need to be housed in rehabilitation step-down rehab units while the fixator is in place, usually several months. Such units are sorely lacking, although Corsu does have one. The profound impact of poverty, particularly with lack of financial resources and private insurance, has meant that the only complex reconstructions taking place in Uganda are in the one children's specialist hospital. The hospital relies heavily on external donations, principally from faith-based NGOs, to provide subsidy support for poor children. The hospital cannot be sustained without charity subsidy support, and NGO support is diminishing as local sustainability is being encouraged and preached. The hospital is forced to charge patient fees to keep the lights on. The result is that the rural poor, the vast majority of the population, continue to lack access. A two-pronged strategy of training and support is necessary. Tertiary public hospitals are where surgeon specialists are trained, but are unlikely to have capacity to perform elective reconstructive procedures in the foreseeable future, while not-for-profit hospitals will continue to provide specialist services. Each needs skills training and material support. To reach the rural poor, however, practical low-tech orthopedics emphasizing early preventive techniques needs to be taught to general medical officers and general surgeons and distributed to district facilities. I believe so much good can be accomplished by practicing and teaching good old-fashioned orthopedics, emphasizing the basic principles of clinical examination and judgment, and not relying on investigations and technology. My orthopedic Bible when I was working in remote district hospitals in Uganda was the 1971 Campbell's Operative Orthopedics, where I learned tried and tested low-tech operations like the Huntington fibula transfer and triple arthrodesis. This was my basic armamentarium, carried up country in a Canadian Tire toolbox, with which I performed hundreds of limb salvaging procedures, watching children crawl in through the doors and walk out, something I have not experienced in my entire practice in Canada. We still make the biggest impact with some of the simplest procedures, and the basic principles are still the most important. Thanks.